Hello and welcome to Talking General Practice, the podcast from GP Online. I'm Emma Bower, the editor of GP Online. Today on the podcast, I'm talking to Dr Katie Bramall-Stainer, the chair of the BMA England GP committee, about what the future holds for general practice. In this conversation, Katie explains why this year's contract deal is the start of a long journey of recovery for the profession and the basis on which to create a more positive future. Now that the government has agreed to negotiate a completely new GP contract, Katie explains what her priorities will be in those contract negotiations and how the BMA will be making the case for greater investment in general practice. Among other things, we discuss whether general practice should be directly reimbursed for staff costs, what should replace the Carr-Hill formula, and whether it's now time to define what core services in general practice actually are. Katie also talks about why GPs need to keep up the pressure in their area to secure better funding for local enhanced services, how she thinks neighbourhoods could impact on general practice, and also why she feels more hopeful about the future than at any other point since she qualified as a GP. I'm delighted to be joined on the podcast now by the chair of the BMA England GP committee, Dr Katie Bramall-Stainer. Alongside her role at the BMA, Katie is also a GP in Hertfordshire and chief executive of Cambridgeshire LMC. Thank you for coming on the podcast again, Katie.
Thanks so much for having me, Emma. It's great to be here.
Let's start with the GP contract for this year. So this is the first contract deal that's been agreed for 4 years, which is obviously a big improvement. At the time the deal was announced, you described this as a turning point. What would you say to GPs and practices now about why this is a good deal?
Well, we have been in the cold for a number of years, and I don't just mean in terms of being able to agree contracts. I mean, in terms of the whole narrative, the whole psyche, the whole hegemony of travel and strategy and direction of the NHS has been moving away from general practice for 15 years or so. And now it feels as if that enormous juggernaut is turning and starting to face in our direction. We are nowhere near being in a place where we can go, oh, isn't everything great? Nowhere near. However, we are at the start of a long journey, I believe, of recovery. This government has said repeatedly to me in private and public conversations that their two big priorities are continuity of care in general practice and improving social equity as well for patients. So if we've got a government that's committed to bringing back the family doctor, if we've got investment which isn't enough, but which is a lot more than we've had historically, so this year's investment is 889 million. You add on the 80 million from advice and guidance, that's 969 million. You add on the bits and bobs that have been committed to us, like 433 million to pay for staff uplifts in DDRB last September, alongside some small PCN and SFE uplifts. If you add all of that together, since July, this government has committed £1.4 billion of new money into GMS. Now, if you look at the 5-year PCN DES framework that was in place from 2019 to 2024, the total funding across the whole 5 years was 978 million into practices. So they are doing what they promised to do. So whilst the government is doing what you want it to do, not everything, but they're doing a bit of what you want them to do, and they're just about to have the greatest reorganisation of the NHS under the 10-year plan, and they're about to have a comprehensive spending review at Treasury. This is so important because you want to be in a frame of mind when you're working with government and you're working with Treasury, when you're about to agree what we want, which is a completely new GP contract so that we can actually get the remuneration and the transformational shift of investment into general practice in a way that otherwise we simply would not be able to. So you're not going to be able to tweak a few little bits into 25, 26 to make everything better. You've got 15 years of mismanagement by successive governments. So this is the very beginning. It's those first building blocks of rebuilding general practice to expand services, to reduce GP employment, both of which directly impact patient access. So my plan this year is for stability, where we see no more practices closing, where we do start to see more GPs in the workforce, better access for patients, more GPs in employed roles, fewer GPs choosing to leave. This is a start of a slow process. This won't be fixed overnight, but at least we've now got a foundation to build from. And at least we're in a position whereby we've got a government that's listening to us. And we've got one very rare and precious thing, which we haven't had in a very long time, and that's trust.
Do you think enough money has gone into the contract this year to help prevent more practice closures? Because obviously that was the massive concern over the last few years, is the numbers of practices that have been forced to hand back their contracts because they just don't have enough money to keep the doors open. Do you feel that this deal this year is going to stop us seeing more of that happening over the coming 12 months?
A safe service for patients with a stable contract with enough money to stop the loss of any further practices closing and to turn the tide on colleagues leaving the profession was key, alongside hope for the future. And I think having a roadmap for what it's going to truly take to bring back the family doctor for our patients, because patients, they want access to a GP, but not just any GP. They want access to their GP. And that's true general practice. That's embedded continuity of care. It's the cradle to grave model with a patient's known and trusted expert generalist gatekeeper. Streeting himself said, look, we've got 1.7 million patients using the NHS every single day. Well, 1.5 million of those are in our practices. So it is obvious to me that general practice is the key to fixing the NHS. And we know this. We just needed politicians and government to understand this and more to do something about it. So that's why we got behind this. It's likely to bring your practice in the region of an additional £7.50 to £8.50 per patient. If you assume the average BMA calculator impact of those budget pressures being almost £3 per patient. That's your ENICs, that's your minimum living wage. You have to do that. You'll perhaps also have seen the Institute for GP Management. Their forecast is a lot more bleak, but their estimate also assumes a maximum cost of maintaining wage differentials. So it's giving everybody a pay lift from the 1st of April before we know what DDRB will announce, before we know what Treasury might agree to later this year to backdate. That's kind of where we are. It doesn't feel like it. I can say, well, this government's committed 1.4 billion of new money into practices, and that's actually over halfway of our original manifesto target of 2.5 billion. But it doesn't feel like it. The money doesn't trickle down. It doesn't trickle down because the contract's broken. That's why the big deal is getting a new contract here.
I'm going to come and ask you some questions about what you want to see from that new contract. But first of all, I just thought it'd be good to talk about some of the things for this year. Now, obviously, you've agreed this contract and you're no longer in dispute with the government. But it doesn't mean that you don't think practices should still be doing some of those things that they were doing under collective action, does it? So you still think that practices should be following safe working guidelines, and you'd still like to see LMCs continuing to push for a better deal for local enhanced services, wouldn't you?
We were really clear from the off. The menu in collective action, separately to that, we were very much promoting our decade-long policy of safe working guidance. And we said, look, this isn't an industrial action thing. This is a policy of ours that's been in place since 2016. It's evidence-based. It takes from the UAMOS, the European General Practitioner Organisation, around what is safe and what is safe for patients and what is safe for GPs. So that's just how it's going to be. That's never going to stop. It can't stop. And in locally, we've very much shifted our approach to our new sort of campaign, which is called Mind the Gap. Now, nationally, you cannot be in dispute with a government for a contract that you have just agreed. But locally, it's a different picture. Nationally, many of the items in the menu for collective action against the government are actually part of potential solutions that we're working towards this year in 25-26. We've already got the resource for advice and guidance. Is it enough? No, of course it's not. We've got sorting out the read and write access for GP Connect update record from October. So locally, the collective bargaining must continue because you've got patient pathways that have not been commissioned where the ICB is responsible, or which have been so poorly commissioned that patients are falling between the gaps and practices are being put at risk. So once you price activity professionally, you really start to appreciate those funding gaps. Once you dissect out of a basket of services, like the cost of an ECG that is being resourced at, and then you look at what the trust tariffs are, or at the community diagnostic centres, they are many multiples of that. So the impact of effective collective bargaining at an ICB level around local contracts, that's the biggest impact. It's bread and butter for what LMCs should be doing. It's ensuring safe patient pathways are in place. And so really, it's the sort of thing that, I can imagine the DH really getting behind, because it helps empower them to make sure that NHS England and ICBs are fulfilling the government's objectives of that transformation into primary care in terms of NHS investments.
There's such wide variation between local enhanced services, though. I mean, we've written a few stories over the past few weeks about some successes, some not so successful negotiations that are going on. Do you think there should be like a national list of how much GPs should get paid for particular services that they provide?
I think that's a really good question, because some things are actually universal and probably shouldn't be in a local contract, because every population is going to require a degree of complex dressing or ECGs or phlebotomy or shared care agreements around prescribing frameworks. But what is truly local might be around refugees, might be around different populations, such as student populations, travelling populations. That's where genuinely your local enhanced services ought to be focused. So your demography of what is required in rural Cornwall will be very different to what's required in rural Sussex. And likewise, what's required in the council wards of Greater Manchester will be very different to the council wards of Bristol. There'll be some similarities, but the big problem is that social equity is perversely impacted by the Carr-Hill formula for funding, which itself is based on data which is now decades old. And our population, our demography, our patients have changed so much. And we can see that from the loss of public health in recent years, where it's been very much landed on general practice. And I think so many support structures in the communities have been evaporated and diminished and demolished, and we have been left to carry the can, that general practice itself is almost unrecognisable, not in a good way, from where it once was and what it could once do. But we've got so much unpicking to be done and such difficult questions. There was the partnership review back in 2018. There was going to be a Carr-Hill review. There was going to be a dispensing review. All of those things were put on the too difficult pile when Jeremy Hunt finished his term of office to become Chancellor and Sajid Javid came in as Secretary of State. So the hard work has got to be done. We've now got less money to do it. So I think that's why you've got these really challenging conversations around, well, if we can't afford it, where does the money come from? And another big reason why I wanted to get this contract agreed was because the geopolitical climate is so volatile. Everything feels very fractious, very uncertain, and money could be suddenly required to be committed to defence, which could freeze other budgets. I think we also very much have a helicopter view of the politics what's going on as well. Everything is a sort of a game here, taking odds and trying to understand what's going on. And that's kind of what my job is on behalf of general practice. That's where I kind of need the profession to trust us a little bit as well.
One of the big changes to the contract this year has been around the additional roles reimbursement scheme and bringing newly qualified GPs into that main pot of money alongside the addition of practice nurses. We've just seen figures of how many GPs have already been recruited. Were those sort of in line with what you were expecting, or are they higher or lower than what you thought?
We don't really know what the numbers are because they've added in lots of other roles into it as well. So the actual numbers of GPs undertaking additional roles reimbursement scheme posts is not well understood. I would also argue that it's Hobson's choice for a lot of those GPs. And until we start to see practices having the financial headspace to be able to commit to substantive permanent posts, it's going to be a challenge. Now, I personally do not believe that GPs are additional. I don't think anyone does. I personally believe this should not be spread across a population footprint of a PCM between 30 to 50,000 people across God knows how many practices, because when you're newly qualified, or if you're in your initial first few years of practice and you're still finding your feet to a certain extent and that pattern recognition is still building and growing, you need somewhere to put your feet under the table. You need somewhere you're going to be working, where you're supported and where you're mentored, where you can have those conversations between consultations, where you can screen message an experienced person that you know and trust to come and have a look at this rash, to come and have a listen to this chest, because that's how you learn. And I really fear for and worry for and feel awful for those colleagues who have just qualified. I wouldn't want one of those jobs. My experience, having been a GP for 17, 18 years, why would we want to give it to one of our newer colleagues who's got all of those years ahead when we want to try and keep them and retain them in the workforce? So I don't think it's going to change any hearts and minds. If people are wavering, do I go to Canada? Do I move to the Republic of Ireland? The GPR's scheme is not going to change those minds. Whereas if this was at a practice level, then I think we could get behind that. And that's partly why there's been a commitment in year with NHS England and the DH to look at the GP in R's roles, because I can see why that might work for NHS England. It feels like there's more control, but longer term, this does not bring back the family doctor. This does not deliver continuity of care. This does not tick the social equity box, because the Health Foundation's research proved that PCN funding has actually increased social deprivation. So it's not helping the government in their objectives. And this is the battle that we've got on. So I want to see GPs in practices where they can offer continuity to patients and feel they've got a really fulfilling and enriched career, not being spread thinly on some idea where you can mop up bits of money. Now, it's good that we've got lots more flexibility around the R's pot, but I would also remind practices, remind clinical directors that any plans to restructure roles or to consolidate around how many, maybe we could just stick to practice nurses and GPs. Well, okay, fine. But first, you've got to make sure you're going through proper HR. You've got to make sure you're going through a proper restructure and consultation, because otherwise you could land yourself in a lot of employment tribunals and hot water and expense. So again, this comes back to the business side of general practice and making sure we're guiding everyone appropriately. Also about trying to do the right thing by the biggest number, which is incredibly difficult.
You mentioned this review of the ARRS that's happening this year. Is that just going to be focused on the GPs and practice nurse element of it, or is it about the whole ARRS? And what do you want to come out of that?
Ostensibly, GPs is what it's focusing on. And we're kind of starting those conversations now. And it's around how things change. And if we've got a new contract, how do we want that to look? Now, I've been really open that if you look back in history, you look at the Red Book contract from 1965, there were ring-fenced reimbursements for staff and for staff on costs and so on. And I can see the attraction in potentially depoliticising that from GMS contractors, because at the moment, everyone gets terribly upset when DDRB opines on what percentage salaried GP should have, and then practices receive insufficient amounts to pass on the full amount, and then everyone's unhappy with everybody else. It would be fairer if that was a much more open dynamic with government. If pay uplifts were recommended, then government transparency would mean that was automatically going to be happening. And it's balancing the needs of employed salaried GPs around getting proper, fair, open funding against the autonomy of the independent contractor status, and ensuring that we're delivering what is needed for that population, where you've got that level of bespoke tailoring of support for your practice demography, because everyone's individual list is totally unique. Or any ideas to consolidate that or to have a one-size-fits-all approach, it doesn't work, because one registered list is completely different to another and requires a different approach because people are different. So this is all about understanding the role of a GP. GPs are core to running the practice, and it is the practice, it is the registered list that is core to the neighbourhood and the health service across the neighbourhood. So let's wind down the narrative and the rhetoric around PCNs and start to better understand this government's current objectives around transformation of analogue to digital, transformation of sickness to prevention, transformation of consolidation of resources outside of hospitals and inside of community spaces, which is much more important for us. In terms of the R's mechanism for GPs, I said to Wes Streeting last July, I've said it repeatedly to Amanda Doyle, to Ed Scully at the DH, to everyone, GPs in R's is the wrong solution to the necessary question. GPs should be based in practices. If it's transparency of funding flow we're looking for, then absolutely we can find solutions around that. And that's one of the examples that I refer to the Red Book as a prime example that we can build upon. But we want to bring solutions here. We don't want to just paint the problems. The problems are well understood. We just want to provide much better solutions, which are better for GPs, better for practices, but ultimately better for patients.
So when you're talking about the future contract, will you be looking at a model where practices receive direct reimbursement for staff? Is that something that you're going to be pushing for? And how could a model like that work? Because we all know that every practice, the way their staff makeup is so different from one place to the next, really.
It is, isn't it? But there could be that reimbursement framework. Exactly. And I think the creation of the additional roles reimbursement scheme is interesting. Obviously, that's at a PCN level, but I really do think we have to start thinking about what's at a practice level. And if the bigger questions are around, well, you can increase the investment into GMS, but then you don't see the outputs. Well, I've got lots of solutions for that. And I think that's such an important question for us to have. There are many things stopping evolution in general practice. And one of them is the Partnership Act of 1890, where we carry unlimited liabilities and which the Secretary of State himself famously referred to as murky business. I kind of think, well, actually, that's not general practice's fault, because they don't want to work under a Victorian piece of legislation where they face unlimited liabilities. They would absolutely embrace and innovate if they were permitted to incorporate, if they could become a company limited by guarantee or by shares, or a community interest company, or a limited liability partnership model, to be enabled to continue to have access to the superannuation scheme and the NHS pension scheme. These are the really big things we need to grapple. Now, the last contract negotiation took 2 years. This, I think, will be much quicker because it will need many hands on deck, but we've also got AI, much more modelling. We can use third parties for expert resources. We've got limited time because any majority government tends to go back to the polls sooner than the 5-year mark. So we would need to have to put the offer to the profession and embed it in either 1st of April or 1st of October 2028. So that gives you a limited time window. And in parallel, we'll be negotiating 26, 27. So it's going to keep me very busy between now and then. And to be honest with you, I'm not really going to spell out all of the ideas I have, because it's going to be a much more iterative process where we can see what's going to be possible. And so much is going to be dependent on the comprehensive spending review that's coming out from Treasury next month, hopefully. And beyond that, with the 10-year plan, they're going to be inextricably linked with each other. So I don't have any control what goes into those documents, and what is going to be the output from those documents will largely determine how successful this contract negotiation is going to be. And we've got to have sufficient resource there. Otherwise, the government's promises will come up wanting the opposite of what they're saying. So I think we're going to have to be a little bit patient to find out where we're going to be.
And in terms of those timeframes, when do you start talking about this big new contract? Is that starting from now, and then you'll do in parallel what's going to happen from April next year? Are they discussions that you're already talking about, basically?
In very broad, high-level terms, yes. But because we've not yet had the comprehensive spending review from Treasury,
right,
because we've not yet got the publishing of the 10-year plan, there's a limit to what DH and NHS England can agree to, because they can't determine their funding envelope and they can't determine their parameters until those documents are understood and in the public domain and have been stamped by government. So it's a little bit chicken and egg at the moment. But I think these broad-level conversations, certainly for us and our side, it's getting out there, listening to the feedback from practices, from younger GPs who want that autonomy, who want an independent contractor status, but who might not want or might not be able to get the loans to be able to have guarantees around premises, for example. So many of these things are linked in with each other. We need to keep quite open at this point. And other examples around social equity and Carr-Hill funding and formulas, a lot of the think tanks have done a lot of work on this. And so a lot of it's also information gathering and understanding. And we're also looking, and we've created a document which is almost at completion now, around the value of a GP. Because if you're looking at this from an economic standpoint, for many years we've said, you could have a physician associate, you could use a paramedic, you could use a first contact physio, you need a clinical pharmacist. Actually, so often it's much more effective and efficient and productive if you have your expert generalist, and they then determine where things need to go. So kind of the PCM model needs to be turned on its head. And again, when you've got your nurse colleagues, district nursing colleagues, it would make so much more sense to have them in practice. The same with your health visitors, your child safeguard and adult safeguarding teams, working close with local authorities. There's so much more that we need from community trusts that they don't or cannot currently deliver, where we could work so much more closely if we had the finances and the resources to be able to do that. And that's all written. This is not a secret. This is not a crazy headline. It's all in our manifesto called Patients First, Why General Practice is Broken and How to Fix It. It's a really amazing opportunity, and I feel immensely privileged to be able to have a small role in helping determine where we go in the future. But I think an awful lot of it needs to be embedded in the spirit of the past, because general practice as a career was, I think, the best job you could ever get. It was absolutely amazing job, but it's been ruined by the pressures of everything else breaking around it that make it unsustainable. And it feels like there's much less joy in it. The joy in the consultation remains when you've got continuity, when you're able to help a patient and you're able to do things. The misery starts when you've got to involve third-party agencies, trusts, community trusts, external bodies, which is going to just not deliver what you or the patient requires. And but I think this is going to be the case for a few years to come yet. But what we need is that light at the end of the tunnel to keep confidence and keep hope, keep optimism, because we've got to get back there. Everyone deserves a good general practice.
So it's really fascinating talking to you about this, because obviously when I first started writing about general practice was when the 2004 contract came in. So like I've been at this for 2 decades now as well. So, and it is a pretty much once in a sort of generation almost. So what's going to be your big priority in this? What's the key thing that you're going to be driving for in these negotiations?
Continuity of care.
Right. OK.
It's the GP patient list size, so that there's adequate resource. We've said in our manifesto, 1 GP per 1,000 patients. And everyone will go, oh, you can't do that. Well, actually, other nations have made significant inroads towards that. Denmark had a system very similar to ours, very acute focused, that 95% ratio of funding. And they've turned it around over a 7-year period. Norway's patient list size is now just under 1,200 patients per GP. Ours is insane now. But imagine what you could do if you had your patient cohort. You would work more hours because you would have very different pressures. There'd be intellectual pressures, or there would be communication pressures to make sure you've got your penetrance and your prevalence into your vaccination uptakes and looking after and preventative work. It would have much more public health attached to it, much more outreach, understanding your council wards and your registered list and all of those societal impacts. It would give you much more opportunity to tailor what your particular population required. And I think we need to start with what the population needs rather than what we've got, because we need to be aspirational. There is so much money invested in the NHS, and a lot of it isn't going to where it really needs to get to. And our population is going to rise, and the complexities are going to rise. And I can't help but think, my goodness, can you imagine if you actually had the resources you needed, even if it were 2,000 patients, it would be unrecognisable as a job to what it is now. And the reason why I know that is because I was lucky enough to qualify in 2008 when things were very different and a lot better and a lot more fun and brought a lot more joy. And I mean that in very much the intellectual side of being an expert generalist and learning your trade and your application to medicine. It was so different to what it is now. Now it feels like it's a conveyor belt. You've got so much pressure and people have nowhere to go, and it's so dispiriting. And that's what's driving people away from the profession. The lack of investment historically as well has been such a problem, where practices just do not have the financial headspace to be able to even hold on to people. And so they're so nervous about what might happen. And that's why it's so important that we will have to keep the pressure on, because we don't know what DDRB are going to recommend. We don't know what Treasury are then going to recommend on the back of it. Rachel Reeves has been very savvy, very sensible. I would do exactly the same if I was sitting in her shoes. I would say, no, public sector, education, health, fire, whatever, you're all getting 2.8%. That's all you're getting. That's it, nothing more. That's exactly what I'd say, because she's got to steady the markets. She's got to do all of that. Now, Labour said something similar last year, but actually then they still came out with 433 million to help supporters. I know it wasn't going to ever be quite enough because of GMS, because the contract's broken, but it's better to have some than have none. This stuff is complicated.
You just mentioned the DDRB there. Do you think it's likely that they will recommend more than 2.8%?
Bloody hope so. We spent a very long time creating our evidence for them. It's a very different experience this year. Last year we spoke to them for about an hour and they're quite dismissive. This year we overran, spoke to them for nearly 2 hours, and they had a much better understanding of all the problems. They were really interested in what's motivating GPs to leave the United Kingdom and leave England in particular, and what's happening to practices that have closed and why they've been forced to merge, and what's then been the impact on patients and access. Far more granular detail and understanding. So that has given me much more grounds for cautious optimism, and the qualitative data as well as the quantitative data that we provided, I think was really compelling. So yeah, they haven't responded yet, and they're meant to, as they've got into trouble with the resident doctors, haven't they? But yeah, I'm optimistic on that front.
You've mentioned the Carr-Hill formula a few times. Basically, there's widespread acceptance that that's probably run its course. I mean, what would you like to see replace that? Lots of GPs that I speak to say they'd like to go back to a kind of item of service model where they claim back for work they've done. Is that something that you would like to see happen?
I mean, item of service is one possibility. It's actually current conference policy for local medical committees, but you've got to look at every option, because you've got to also understand what's going to be affordable, and careful what you wish for, because if you want an item of service contract, but that's only going to come if you have to become part of an acute trust and you lose your autonomy, lose your independent contractor status, then I think that would be tricky as well. So Carr-Hill's flawed, but we have to consider what might replace it. how the current funding formula could be improved, because we don't want to create huge disruption to practice finances. So at the moment, you've got winners and losers. But what you need to make sure is that that variability is minimised. So basically stretch out your bell curves so it's as wide as possible. That means engaging with subject matter experts. And there are various academic units across primary care departments in the country, as well as think tanks, as well as some charities and the wider profession to assess what might be the best way forward. And we're having those conversations already.
You've said that to fund general practice properly, we need to work backwards from what the government wants general practice to deliver and then cost it up and commit funding for patients. I believe you said that on X. But to do that, do we need to define what core general practice is, what core services in general practice are? And if so, how do we do that?
Personally, I think we do. But I know that it's a broad church out there. I think historically it was always, don't define it. And I think that might have been true then, but I'm not so sure it's true now. Essential services are actually already defined within the GMS contract and regulations. So by their very nature, contracts don't simply allow unlimited workload without additional resource to support negotiated variations. So I think if you deviate from that you simply risk collapsing services because you're going to have under-resource and overwhelm. So a new contract has got to establish what essential services patients need, what the government and Treasury using taxpayers' money can afford to pay for. The really good thing is the British Social Attitude Survey, which again demonstrates almost exactly half the population want to increase their taxes if it's going to the NHS. They understand that they're getting a very good deal and they want to pay more to get more back. That's really good news for us, because if you're going to invest anything in the NHS, you should invest it in general practice to get the biggest bang for your buck. The services that are specified within the GP contract have got to be fully resourced. So you've got that safety sorted out and you've got practice sustainability over a longer term. We've got to make sure general practice remains rewarding, manageable over the long term for practice staff, not just for GP. It's got to be fully collaborative. It's got to have mutual faith and confidence and trust in the key stakeholders so you got the best outcomes. I think this is going to be difficult. I'm not under false illusions here. I think there's going to be some very challenging conversations with government and also with the public. If we're going to meet all of patient need, then we're going to have significantly more resource. We know that from the long wait that many patients still have to see a GP, from the massive commissioning gaps that are visible from space that currently exist across so many of our communities. If you look into and do some research, I know that Richard Wood, who's a colleague of mine, chief exec of Berks, Bucks and Oxfordshire LMCs, he's done some research across the Oxfordshire footprint, which looks at numbers of appointments and those patients that wanted an appointment but didn't get one. We're seeing so many patients, like 1.5 million a day. The evidence is that you could almost see almost double that. So are you ever going to fulfill patient need? If you're not, we're going to have to understand, what do we do to protect the most vulnerable? What do we do where there are complex additional healthcare requirements? How do we look at, when you've got avoidable attendances, urgent and emergency care pathways are just really flawed. So I think the next definition of essential services is going to be influenced by the government's prevention first agenda, that whole continuity of care and social equity. So I think that's important to think about. They've been very clear on their headline themes, and I'm certain they will heavily inform the direction of travel that they want to see.
The 10-year plan that's due in the next couple of months, well, everybody seems to think that neighbourhoods are going to basically be a key part of that. What needs to happen, do you think, to make sure that general practice is at the heart of neighbourhoods? Do you think neighbourhoods are going to be part of this ongoing contract negotiations you're having?
Yeah, they keep talking about them, don't they? But I don't quite know what they are yet. I think the 10-year plan is going to be helpful in terms of spelling out what they really mean. Although there were always plans around integrated neighbourhoods going back into the 1920s and 1930s before the NHS was founded in Labour Party policy. And I think a lot of it goes back to that kind of social cohesion, social alliance. If you're going to distill this into a really short answer, you want to keep the public's local GP practice as their front door to the NHS. Now, that has been absolutely eroded from years of underfunding and the introduction of other services that duplicate and do not complement where we are. So 111 urgent treatment centres, that's got to be sorted out alongside it. Patients have got multiple access routes into the NHS, but they often feed back consistently, repeatedly. They just want to be able to get to see their GP when they need them. We are the best patient advocate. We're the best placed person to ensure when you navigate NHS pathways in the most efficient way, it works. We cost so much less to see us. We are the best gatekeeper. The NHS won't work without a really robust gatekeeper function. And if you absolutely break the gatekeeper, you will break the NHS. And that's exactly what we've seen. The Health Foundation analysis I'm quite fond of. We've got thousands of GPs short of where we need to be to meet patient need. So fine, okay, neighbourhood practices, no problem. We're going to need to look at premises though, maybe co-location of diagnostics, health hubs with, for example, what used to be Sure Start, or complementary primary care such as dental or optometry or pharmacy. We need some diagnostic access. We need our health visiting and district nurse colleagues potentially. So if it's around how you would fund that transformation, then you're going to need to have bricks and mortar. And maybe that's where this comes in as well. This is really exciting. You might say, oh, it sounds a bit like a polyclinic. Well, I was a registrar when polyclinics were being voiced by Darzi. We're in a very different space now, but the public still wants and loves and owns the concept of their GP. And that's the essential elixir of what we need to secure in the future.
When you were first on the podcast, just after you were elected as chair of the GPC, you said that one of your big priorities was to bring hope back to the profession. And I was wondering, now we're in the position we are right now, do you feel hopeful about the future for general practice?
Yeah, I do. I feel more hopeful for the future for general practice at any time than I've done since I qualified. And that might not be visible to all my colleagues and peers, but that's kind of why some need to trust me a little bit on that. And also 85% of GPC England voted in favour for those reasons. We can see the direction of travel. We can see these conversations. People are coming good on their promises. And a lot of this is based on trust. So it is with a bit of a wing and a prayer. And I said, look, I think we need to agree to this because I think the Secretary of State has good intent and I think he will agree to a new contract. That was my gut feeling. It was a hunch, and he has done. Without precondition, he said. That's really important. Things are moving in our direction. We're not there yet. We are nowhere near there. I don't want any listener to this thinking, I think that this year's contract is great and that advice and guidance is marvellous. Don't be daft. I'm a GP too. I know what it's like. But we are so different to where we were 2 years ago. And I'm so glad. That doesn't mean to say the job is done. The job is only just beginning, but at least we can actually do a job if people are listening to us, because all it was before was just banging against a closed door. The door is now open. So now the case has to be made and we have to really fight for general practice.
Thank you very much, Katie. I really appreciate your time today. Thank you.
Absolute pleasure, Emma.
Well, that's it for this week. Thanks so much again to Katie for taking the time to talk with me, and thank you for listening. I'll be back next week for our regular review of the key news stories affecting general practice. In the meantime, don't forget you can keep up to date with all the latest news and access lots of other resources and information on our website at GPonline.com.